And now we're going to talk about the gastrointestinal anomalies. The gastrointestinal assessment will include the evaluation of the abdominal wall that is commented in a previous lesson, and the evaluation of the intra-abdominal structures. At the intra-abdominal level, we shall evaluate the stomach, the presence of it, the cetus, its size, the peristalsis, and the content. We will assess as well the intestines, its echogenicity, if there are dilations, the presence of the liver, gallbladder, and the bladder. The correct evaluation of the intra-abdominal content. The gastrointestinal assessment in fetal life will change due to the peristalsis. This will make that the images seen in second trimester are different from those seen in third trimester or at term. And it will be important to assess as well the amniotic fluid, because we know that the swallowing and the intestinal peristalsis are important regulators of the quantity of the amniotic fluid. The majority of the pathologies found in fetal life are obstructives. Therefore, we will find an increased amniotic fluid. That is why the amniotic fluid assessment will be part of the evaluation of the intestines in fetal life. We will start with the esophageal atresia. The esophageal atresia is a pathology where there is no connection between the stomach and the esophagus. There is an interruption of the last one. It is a frequent pathology that affects 1 in 2,500 to 4,000 newborns, but the detection rate is low. It doesn't exceed 50%. This is because there are different types of esophageal atresia. It can be associated to a tracheal esophageal fistula, as you can see in the skin in the third case. There is a fistula that is proximal to the defect. In the fifth case, the fistula is distal to the defect, and in the last case, we will have double fistula. The sign that can help us to identify the esophageal atresia is the no visualization of the stomach. In this video, we do not see the stomach. We see the abdominal wall, the umbilical vein, but we do not see the stomach. Nevertheless, the cases in which we can suspect the pathology in which we do not see the stomach are those in which the fistula is proximal to the defect, or in the case there is no fistula. In that way, there won't be communication between the trachea and the stomach. This represents only 9% of the esophageal atresias. The majority of esophageal atresias will present with normal stomach or with a reduced stomach, and this will be the challenge. To find a small stomach will be operator dependent. There are normality curves, but it is a subjective evaluation, which will change throughout the gestation. The other sign that will help us with the diagnosis is the presence of polyhydramnios. If we add the presence of a small stomach with polyhydramnios, we can achieve positive predictive values of 56%, although the detection rates are still low. Nevertheless, polyhydramnios will be detected only in 1% of esophageal atresias. The majority of polyhydramnios are caused by other pathologies or are idiopathics. Additionally, the polyhydramnios in the esophageal atresia will be The polyhydramnios in the esophageal atresia will be a late sign, because it will need for the following of the features to be present, and that is only achieved in late second trimester. As we can see here, polyhydramnios can have a lot of causes. But if we join the polyhydramnios with the non-visualization of the stomach or the reduced size of the stomach, the predictive capacity is higher. Other thing that can help us identify the esophageal atresias is the identification of the pouch sign. The sign represents the dilation of the proximal portion of the esophagus prior to the obstruction. This is a late sign as well, because it requires the strength of the following of the features to dilate the proximal part. When we identify it, it's a very specific sign, but the identification of it is infrequent. If we do identify it, the location can help us predict if it is a complex esophageal atresia. The proximal it is, the greater the atresia will be. On the contrary, than when seeing it in a more distal part. This is associated to more anomalies and more difficulties in the surgical repair. This is an antique video, but very representative. This is a cervical pouch sign, which is very proximal, in which we will predict there is a great atresia zone and therefore worth surgical correction. At last, the growth restriction we have talked about, small stomach, polyhydramnios, pouch sign, and there is then the growth restriction due to the malabsorption of nutrients in these fetuses. When facing an esophageal atresia, we have to perform a detailed anatomical study, which can be associated to other pathologies, gastrointestinal, of central nervous system, congenital heart diseases, and others. It can be part of syndromes as factor or charge. We must perform an echocardiography to rule out anomalies. And last, we will perform an array. It will be important the counseling with the pediatric surgeons. And, as we said, we are only going to detect between 10 to 40% of cases. Having this low detection rate, we have to think if there are other studies that can help us detect these esophageal atresias. Between them, the MRI. There is a preliminary data that shows that it can be useful when assessing this pathology. Nevertheless, as a screening method, it has a high rate of false positives because it's based in the no identification of the esophagus, which can occur frequently in normal cases. Nevertheless, in those cases in which there is an ultrasound suspicion, it increases the positive predictive value. It is based in the identification of the pouch sign, in the no identification of gastric camera, and it could even identify the fistula. And as we can see here in the MRI with dynamic sequence increases the sensibility of the detection of esophageal atresias in 80%. And if we add enzymes to the amniotic fluid, we will increase the detection rate even more in those cases of ultrasound suspicion. The management will include a strict follow-up. It has a progressive increase in the amniotic fluid, which will lead to high risk of premature delivery. We must be prepared in cases there is a short cervical length with severe polyhydramnios to perform an amniotic drainage, needed to reduce the risk of premature delivery. We will assess as well the fetal growth and the appearance of other anomalies. Especially, it will be important to deliver this baby in a third-level hospital, so the diagnosis, management, and treatment can be done since the baby is born. It will be very important to assess the risk of prematurity, to assess the cases where there is severe polyhydramnios or shortening of the cervical length, because in the isolated cases, the principal prognosis factor is the prematurity. As we can see here, the survival rate is reduced as the gestational age of delivery is earlier, or with associated anomalies. So it is important in the isolated cases, it is important to evaluate the risk of prematurity. And here we can see that the prognosis is different in prenatal series, in which there is a high association to other anomalies, especially chromosomal anomalies or severe anomalies as severe congenital heart diseases, neural tube defects, central nervous system anomalies, or others. The postnatal cases, the survival rates are higher. The association to chromosomal anomalies is lower, and so it is its association to severe anomalies. The treatment will be surgical procedure. It's not urgent. There is time to plan. It consists in bringing together the proximal and distal part of the esophagus. The ideal thing will be to do it directly, but sometimes there is need to use intestine inserts in order to achieve it. And as long-term consequences, there is fistula recurrence or the re-stenosis and reflux, but in general conditions, they have a good prognosis. Here we can identify a postnatal stage, in which we can see that the catheter does not pass through the esophagus. There is a stop at this level. This is another example of the pouch sign dilated with contrast, and how in the post-surgical stage there is pass through the intervened zone and with a correct filling of the contrast from the mouth to the stomach. The next pathology will be the stenosis or duodenal atresia. It is a pathology that will affect 1 in 5,000 newborn, and it's an obstruction that will consequently give a dilation of the first portion of the duodenum. The obstruction can have two etiologies, intrinsic and extrinsic. The intrinsic is the one where there is a lack of permeabilization of the intestinal lumen. The extrinsic is due to external factors, which can be the presence of membranes and intestinal rotation, of the presence of abdominal cyst, or the most frequent one, the presence of an annular pancreas that causes constriction of the zone of the duodenum. The diagnosis is late because the signs don't appear until 22-24 weeks of pregnancy. The diagnostic guide will be the presence of the double bubble, all that associated to an increased amniotic fluid due to the obstruction. These are signs, as we commented, that will appear from the second trimester of gestation. This makes that the detection rate doesn't reach the 50% of cases and is made after the 24 weeks of pregnancy. The principal diagnosis will be with the intra-abdominal cyst, generally with bile duct cyst. In this case, it will be important to diagnose it with the double bubble sign, in which we can prove the continuity between the stomach and the dilated first portion of the duodenum. This dilated zone communicates all the time with the stomach. There is no membrane or other structures in between. This is a large stomach that exceeds the midline, and also the two bubbles are communicated, in difference with a duodenal cyst, in which we see an abdominal cyst that does not communicate with the stomach, and that is in the other side of the abdomen. Therefore, regarding this double bubble, it is important to see the continuity between these two. When facing the diagnosis of a duodenal atresia or stenosis by seeing the double bubble, we have to perform a detailed anatomical study, because it is also associated to other structural anomalies. Ask for an echocardiography. We will ask as well for an array, because until 50% of cases of duodenal atresia can be associated to aneuploidies, especially 21 trisomy, and also a multidisciplinary counseling, especially with pediatric surgeons. The obstetrical management will be the same as in the esophageal atresia. Evaluate prematurity signs. Follow up every 2 to 4 weeks depending on the quantity of amniotic fluid and the evolution, and especially evaluate fetal growth, because this is very frequent. The delivery will be coordinated in the third-level hospital, where the prenatal management can be done. Regarding the prognosis, it has a different prognosis those cases diagnosed prenatally than those diagnosed postnatally, because there is a high association to chromosomal and structural anomalies, and these conditions a high rate of interruption of pregnancies. Nevertheless, regarding the isolated cases, the survival of prenatal and postnatally diagnosed duodenal atresia is similar, and the prognosis is a little bit better if diagnosed prenatally, because this allows to coordinate the delivery in a proper center, and these children will arrive in better conditions to surgery. We can detect them in less time of performing complementary studies, and better preoperatory stabilization, less acidosis, less dehydration, and usually there is less time till there is oral tolerance. The surgical procedure consists in duodenum duodenostomy or duodenum jejunostomy, and there are few long-term complications. Here we can see, or we can identify, a case of duodenal stenosis, in which there is an annular pancreas, as you can see marked with the arrows, and was externally constricting this duodenal zone. And here we can see the repair with a duodenum duodenostomy. And the last pathology that we're going to talk about is the intestinal obstruction. In the ultrasound, we will see an intestinal dilation. As we can see in this image, this intestinal dilation will be an important guide sign to those cases of intestinal obstruction. Before diagnosing an intestinal dilation, we have to think in which gestational age are we in. We know that at the 20 weeks of pregnancy, in the ultrasound we should not see the intestine, nor the large nor the small bowel. But progressively, while the gestation age increases, it is more frequent to identify the intestinal loops, especially of the large bowel. And when are we going to consider a loop is dilated? The truth is that there is no cutoff point with sufficient specificity that will help us detect intestinal obstructions. But to keep in mind, in third trimester, an intestinal loop of more than 20 mm of diameter in the large bowel and more than 7 mm in the small bowel will be enough criteria to suspect a severe intestinal obstruction. As we have said, it is important to assess the intestinal loops regarding its gestational age. It's not the same to identify an intestinal loop like this in second trimester than at term. We also know that if we identify a single dilated intestinal loop, it can progress in an important way throughout the gestation, because if there is an intestinal obstruction, all the intestinal content will start accumulating before the obstruction, and this will allow us to see different images throughout the gestation. This is the reason why it is difficult to determine if there is a single or multiple obstructions and in which level. What we do know is that by frequency it will be a small bowel obstruction, which are considered dilated when they are higher than 7 mm, are centrally distributed and have peristalsis, in difference with the large bowel obstructions, which are less frequent, with peripheric dilation and larger dilations and with almost no peristalsis. However, the differentiation between one and the other are theoretical, and sometimes in the images can be very similar in one and in the other. For example, we can have this image that we're seeing here on the left of a fetus of 20 weeks in which we thought it could correspond to a large bowel obstruction, because with a single loop distally located, but when assessing the same fetus in third trimester, we could evidence that there was a massive dilation of all the loops, diagnosing this as a small bowel dilation. In this video, we can see the peristalsis and the dilation of the loops. Therefore, always when facing an intestinal dilation by frequency, we will think we are seeing a small bowel obstruction. It affects 1 in 2,500 to 5,000 newborn. We have a detection rate of 40%, low, and the guide sign will be the dilation of the intestinal loops, which as we said can be single, multiple, and massive multiple dilation. There is a recent study in which they stated that the detection rate can be increased by assessing these intestinal loops in third trimester, after 32 weeks of pregnancy, considering dilation and intestinal loop of more than 17 mm and associated to polyhydramnios. In those cases, the detection rate will increase till 66%. Other signs that can help us in the diagnosis of an intestinal obstruction when seeing an intestinal dilation are the finding of echogenic zones, an increased peristalsis, intra-abdominal calcifications or hyperechogenicity, or thickened walls of the intestine, which cutoff point will be 3 mm. Regarding the differentiation of jejunum or ileal obstructions when facing a small bowel obstruction, it is also impossible to differentiate in prenatal life. It's described that the ileal obstructions are more frequent, and they are usually singles, with more perforation tendency. The loops are more dilated, and there is less polyhydramnios because it's more distal. Nevertheless, it is impossible to differentiate between those two. Additionally, in 10% of cases the obstruction will be multiple. The intestinal obstruction will be more frequent the more distal it is, because there will be more dilated loops. The prognosis of the intestinal obstruction will be dependent on whether it is a small or large bowel dilation. The small bowel obstructions, jejunum ileal obstructions, are the most frequent, have less association to chromosomal or structural anomalies. It is associated with cystic fibrosis, especially if there is meconial peritonitis or if there is an increased echogenicity in the loops, and generally have good prognosis and the terminal or terminolateral anastomosis is done. The worst prognosis will be in those cases in which by non-use we find an apple peel intestine, which is practically useless, will have difficult perinatal and surgical management, because usually there is a large portion of the intestines which are in poor conditions and there is the necessity to resect large portions of it, resulting a short intestine syndrome as a consequence. The large bowel atresia are less frequent, are more associated to anomalies and structural anomalies as congenital heart diseases, skeletal, renal, and others, can be part of Vector syndrome, and in these cases the prognosis will be conditioned by the associated anomalies. The management of this pathology will include the detailed ultrasound, echocardiography. We will perform a molecular karyotype, assess the cystic fibrosis. We can ask for an MRI, which could help us with the level of obstruction. Although the sensibility is not that high, and especially a multidisciplinary counseling with the pediatric surgeons. The prognosis will be conditioned by the associated anomalies, as we have said, and the neonatal management. The follow-up, as is done with the esophageal atresias and the duodenal stenosis, will be focused on detecting those signs of risk of prematurity and detecting the appearance of associated anomalies. The delivery can be at term, with vaginal delivery in a third-level hospital, in which an early surgery can be planned. At last, we want to comment a possible complication regarding intestinal obstruction, and is, as we can see here, a sign that is compatible with meconial peritonitis. We can see ascites. We were following up this patient because we suspected an intestinal atresia. And in the surveillance, we could see an ascites appear with intestinal echogenicity and massive dilation. All that makes us think we are facing an intestinal obstruction. The meconial peritonitis is caused due to an inflammation of the intestinal loops because of an intestinal perforation. The intestinal content is output into the abdominal cavity, which will provoke a chemical peritonitis. It is more frequent if found associated to intestinal atresia, intestinal malrotation, volvulus, or cystic fibrosis, and is infrequent to be spontaneous. Although we have to think on it, in cases of amniocentesis was performed, especially during the transplacentary ones, and we find in a fetus that previously didn't have any malformation and intestinal dilation, with echogenic stomach content. This fetus probably had swollen blood, and this blood produced an intestinal impactation, which will cause a perforation at the level. The prognosis of this last case will be different from the one an intestinal problem was established. The ultrasound signs that will help us identify the meconial peritonitis are the appearance of intra-abdominal calcifications, generalized ascites, intestinal dilation, pseudomass, or polyhydramnios. And here we can see the recently described signs associated to meconial peritonitis, associated to intestinal pathology, and that require surgical treatment postnatally, which are the presence of ascites, the bowel dilation, and the echogenic bowel. Generally, when facing a meconial peritonitis, the ideal management will be the expectant one, because it's a fetus that usually has an intestinal obstruction that was complicated by a perforation, and we shouldn't add more risk as is the prematurity. It is a sterile peritonitis that can heal prenatally. Here we can see other associated signs, as are the intra-abdominal calcifications. The presence of a pseudomass, in which there is a peritonitis that has been encapsulated. Fibrous reaction was created surrounding the zone that was perforated and gave the aspect of a pseudomass, which can generate hemodynamic problems and a more difficult repair in the postnatal surgery. To end, we have to talk about the different problems we can find in the digestive system of a fetus. We have talked about esophageal atresia, the duodenal atresia, and of the intestinal obstructions. And these anomalies have a late and infrequent diagnosis in antenatal life. When suspecting an intestinal obstruction, we have to perform an exhaustive study, mentioned before, and a multidisciplinary management. Especially assessing there are no associated anomalies, nor chromosomal anomalies associated. We will always offer an invasive procedure, an echocardiography, and a detailed anatomic evaluation. The follow-up should be serrated to detect risk of prematurity, the necessity of amniotic drainage, and we will plan vaginal delivery in a third-level hospital at term if it is possible.